Hello and good evening, everyone. Welcome to our 24th World Virtual Seminar. World Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this program is brought to you by Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Getachew. I'm the co-founder and CTO at Ethiopia. And today we have Dr. Desta with us. Dr. Desta is an assistant professor of ophthalmology at Haramaya University. And he's going to give us a presentation, a brief topic on common causes of blindness.
Thank you very much, Adam, for your nice introduction. Welcome everybody to today's webinar on common causes of blindness. So as you can see from your screen, today's topic is common causes of blindness. We will try to focus on things that may help you with your AMP exam with regard to ophthalmology. So here we go. So let's start by defining what is blindness. So blindness is defined as a visual acuity of less than 360 in a better eye with the best possible correction. So the key thing here is we define blindness after we correct with everything we have at our hand to get the best possible vision. And if that best possible vision is less than 360, or if the visual field is less than 10 degrees, that is, it's a very constricted visual field, then we define that as blindness. So what we mean by 360, 618, or this kind of numbers is that always the denominator indicates the average normal people's capacity to see, and the numerator indicates what our client or our patient, the distance the patient can possibly see. So what we mean by 360, for instance, is an object that can be seen by the average normal individuals from 60 meters. Our client can only see it at 3 meters. So he has to come very close. So someone with normal eye can see it from 60 meters, but our client only can see it 360. So this is, so for instance, the normal vision is 660, 6'6". So the average individual can see it from 6 meters, and you can also see it from 6 meters. So 6'6" is a normal vision. So low vision, the definition of low vision, so blindness is this: low vision is less than 618 or less than 20 degrees. So the central vision less than 20 degrees, we defined that as low vision. So this definition can vary from university to university, from setup to setup, but this one is from WHO. So near normal vision is from 612 to 618. Low vision is always less than 618. It is usually an exam question. So vision less than 618 is low vision. Vision less than 360 is blindness. Other than that, we have moderate vision, moderate visual reduction, severe visual reduction. So the numbers, as you can see from your screen, is they range from 618 to 660 for moderate, and from 660 to 360 to severe. So blindness, we have already defined it. WHO estimates that there are more than 44 million blind people in the world today. This is the data from in the early 20s. 90% of the world's blind live in developing countries, mostly in Asia and Africa. And the risk of blindness in many of these neglected communities is higher, at least 10 to 40 times higher than in the industrially developed regions. So we'll try to see, when we come to the individual diseases, we will try to justify this. Around 80% of blindness is treatable and preventable. This is a good news. So 80% of it can be either prevented through different measures, or once the disease happens, it can be treated. For instance, cataract is a good example for this. Every 5 seconds, 1% in our world goes blind, and the child goes blind every minute. So blindness in general can have other comorbidities. So it may be associated with mental retardation, autism spectrum, cerebral palsy, hearing impairment, epilepsy. So, you know, the eye is only the window. The eye is only the window. So whatever we see through our eyes should be interpreted within the cortex. So usually the occipital cortex. So the image from the eye reaches to the retina. Once it reaches to the retina, it goes through the optic nerve, to the optic chiasm, from the optic chiasm, some decussation happens. So some of the image from one eye will around 53% will go to the other part of our brain, the other half of our brain, and this information goes through the optic tract, then the lateral geniculate nucleus, then through the optic radiation to the cortex. So anything, so other than the orbital part of the optic nerve, as you have heard, everything is in the brain. So anything that causes mental retardation, autism, cerebral palsy, hearing impairment, epilepsy, can have associated blindness. So this is a simplified coronal view of our eye. As you can see, we have on the anterior most part of our eye is a cornea. Then when you come posteriorly from the cornea, is the sclera. The second layer is the choroid. The choroid anteriorly becomes the ciliary body. And the most anterior part is the iris. The most inner part of our eye is the retina. So this is the most important part of the eye where the visual information starts to form. So anything that affects the cornea up to the optic nerve can result in either visual impairment or blindness. So for instance, any kind of infection that happens at the anterior aspect of the eye, the cornea, for instance, keratitis, or change in shape of the cornea, that, for instance, conical protrusion of the eye, which can result in distortion of image. Anything that happens in the anterior chamber, here, for instance, hypopyon, which is called, which is an accumulation of pus in the anterior chamber, or when, for instance, in hyphema, where there is blood in the anterior chamber, or sometimes post-uveitic, so inflammatory cells in the anterior chamber can obstruct the passage of light through the cornea, through the anterior chamber, through the lens, to the retina. So anything that physically obstructs this can result in visual impairment or blindness. So whenever we, as an ophthalmologist and as general practitioner care physicians, whenever we see someone with visual complaint, so this anatomic structure should come to our brain. So is it from the anterior chamber? Is it from the cornea? Is it the AC? Is it the lens? Is it the vitreous chamber? As you can see, the vitreous chamber is the largest part of the eye. So sometimes in diabetic patients, hypertensive patients with retinal detachment, vitreous hemorrhage can happen. So physically, the light may not reach the retina. Sometimes the disease could be intrinsic to the retina. A lot of kind of infection can affect the retina. Dystrophies, there are so many hereditary transmissible diseases that affect the retina. And the other important structure is the optic nerve. So the optic nerve, as you can see from the image as well, my cursor is now around the optic nerve. So anything that affects that also can result in visual impairment. So the summary of what I said so far: media problems, retinal problems, neural visual pathway problems can be summarized as possible cause of visual impairment or blindness. So this I have already mentioned, media problems like keratopathy, hyphema, which is blood in the anterior chamber, lens changes like cataract or subluxation or dislocation of the lens, or which is called ectopia lentis, vitreous hemorrhage when there is blood in the vitreous chamber uveitis, that is an inflammation. Endophthalmitis, that is an infection. Sometimes a sterile endophthalmitis, but it is more or less inflammation of the fluid part of the eye. So retinal disease includes vascular occlusion, retinal detachment, acute maculopathy, age-related macular degeneration, diabetic retinopathies, CME. You know, the textbook has over thousands of diseases that can affect the retina. So let's come to the actual disease entities. In developing countries, cataract is a leading cause. Cataract, what is peculiar about cataract is it is also common in developed nations. The commonest cause of blindness, both in developed and developing nations, is cataract. So with trachoma, glaucoma, leprosy, onchocerciasis, xerophthalmia. Xerophthalmia means dry eye related with vitamin A deficiency, can are important causes of visual reduction. So here you can see cataract, trachoma, glaucoma. We will come to the individual entities of the disease. In more developed nation, cataract still is the most important cause. So here what I want you to know is, if it is blindness that you are asked, cataract is the commonest cause in both developed and developing nations. But if it is visual impairment, and if you have an option of refractive error is the commonest cause of visual impairment, not blindness, but impairment in developed nation. So the other possible, common causes are glaucoma, age-related macular degeneration, corneal opacity, diabetic retinopathy, childhood blindness. These are in more developed nations. In Ethiopia, a national survey conducted in the, I think, in the early 2000s, around 2003, the prevalence of blindness was estimated to be 1.6%. And visually impaired individuals in Ethiopia are, from the total population, 3.7%. Childhood blindness, 0.1%. You see, I want you to emphasize on these numbers, especially those of you who are going to take residency matching exam, because these are common questions. The rate of blindness in the country, and this kind of questions are common. The commonest cause of blindness in Ethiopia, in the world, in developing nations. So cataract is the commonest everywhere when it comes to blindness. In Ethiopia, followed by trachoma and other corneal opacity causing diseases like measles, vitamin A deficiency. Glaucoma and others currently are becoming common. So let's come to the first disease that we'll discuss. So cataract. Okay, so as you know, cataract is opacification of the lens. So the cause of that opacification can be very different. So the lens, you have seen it from the previous picture. It's a transparent biconvex structure with an outer acellular capsule. It provides 1/3 of the refractive power of the eye in an accommodated state. The lens is around 4 mm thick with 10 mm anterior radius of curvature and 6 mm posterior radius curvature. So these are just the details. It may not be very much important for you, but you should know the dioptric power of the lens. So the dioptric power of the lens is 15 to 20 diopter. Generally, the total dioptric power of the eye is 63 diopter. So out of that, 20 diopter is from the lens. The rest of the refractive power of the eye is from the cornea. Cornea contributes for about 43% of the refractive power of the eye. So the commonest, or the highest share of refractive power is taken by the cornea. This is also usually an exam question, followed by the lens. So the lens has an overall 20 diopter refractive power. So this is the anatomy of the lens. So the outermost layer is the cortex, I mean the capsule, then it has an epithelium, then cortex, adult nucleus. You know, these are the details. If you are interested, you can read, but this is not much important. So as I have already said, cataract is the clouding or opacification of the lens, which results in visual impairment or blindness. The Greeks used to call it cataractos to mean waterfall, because when you see the eye, it seems, you know, a waterfall. It looks like a waterfall. So classification of cataract can be, you know, anatomically or etiologically, especially when in pediatric cataract has its own classification. But in general, the anatomical classification is based on the anatomy we discussed earlier. So cortical cataract, if the opacification is mainly on the cortex. So when you see it clinically, there are white wedge-like opacities that start from the periphery. So the other is nuclear cataract, keeping the nucleus of the lens usually associated with aging. Cortical cataract, you know, it looks like a spoke-like fashion. So an ice. So if you see an ice, it looks like a cortical cataract. The other is subcapsular. So we have seen the outermost layer of the lens is capsule. So especially on the posterior capsule of the lens, it usually gets opacified. This is usually associated sometimes along with nuclear cataract. This is usually associated with patients who have diabetes mellitus and who are for different reasons taking high dose of steroids. So etiologically, congenital or infantile cataract. So don't be surprised if you see a newborn with cataract or a neonate or, you know, infants or teenage. Everybody can have cataract. What differs is the cause of that cataract. So congenital or infantile cataract, the commonest cause is idiopathic. We don't know what causes it, followed by hereditary causes, especially autoimmune diseases also can result in cataract. The hereditary type, the main mode of inheritance is autosomal dominant type, but still AR or X-linked are also possible, but the commonest types are autosomal dominant AD types. When we come to acquired cataract, they could be senile cataract, which means related with aging, traumatic cataract, metabolic cataract, for instance, diabetic patients, toxic cataract, like we mentioned earlier, with the use of steroids and other drugs. The others associated with syndromes, like for instance, patients with Down syndrome have higher risk of developing cataract than others. Clinically, it could be immature, mature, hypermature, or Morganian type. So the importance is whether the vision has reduced to blindness or visual impairment. But clinically for us, especially for those who are interventional with eye care, when the cataract reaches to hypermature and Morganian, the risk of complication increases significantly. So we call hypermature cataracts when there is lysis of the cortex, which results in shrinkage. And clinically, we see it through the slit lamp as wrinkling of the capsule. So when it passes this stage, it starts to liquefy, and through that, you know, some particles of the cortex can leak through the cortex into the anterior chamber, so they may result in inflammation. These hypermature cataracts can result in, you know, they can go. We may discuss this when we talk about glaucoma, but they can result in glaucoma. So cataract is treatable, but it has to come at the right time. In my experience, I have seen so many patients with simple cataract who they did not get any treatment, so it became hypermature, then resulted in, you know, phacomorphic type of glaucoma, then permanent blindness. So cataract is treatable, but it will come with time. So this is a simple picture showing a white pupillary reflex. This is a typical picture for cataract. So this is also, I don't think it's very clear picture on your screen, but still cataract. So you can see the cornea is clear. Behind the pupil, there is an opacified structure, which is a lens, and this cataract. So this is a hypermature cataract. As you can see, there is a kind of wrinkling on the surface of the anterior capsule. So this kind of cataract, even when you do the surgery, the kind of difficult surgeries, the complication rates are higher. So what are the symptoms of cataract? Progressive painless reduction of vision. Sometimes, especially with those in cortical cataract, they may experience glare in their own language. So they may complain deterioration of vision in bright light, because in bright light, the normal response of the people to bright light is constriction. So if especially patients with nuclear cataract, since the opacity is condensed at the center of the lens, when the people constricts, the vision get worse. So they may complain second sight, sometimes as a double vision. So they may have decreased color vision. Okay, so the signs are cataract is straightforward for diagnosis. Every physician should be able to diagnose cataract. So the patient is complains with visual acuity reduction, and when you see it, even sometimes with torch, mature cataract can be seen. So there are a lot of complications from cataract, but the common ones are uveitis, as I told you earlier. If the cataract reaches to the level of Morganian type, there will be leakage of cells to, lens particles to the anterior chamber, which results, since these are protein materials, they may result in inflammation. So this inflammation can turn into glaucoma, inflammatory type of glaucoma. So we call it phacolytic glaucoma. Or the glaucoma could be due to the hypermature cataract, which is a kind of angle closure glaucoma. So any kind of glaucoma is possible with cataract. So the other complication is the lens could be, dislodged from the usual anatomic place, and it might come to usually to the anterior chamber. So this is another complication. So how do we treat? Conservative treatment if the visual acuity is better. If it does not reach to severe visual impairment or blindness, we can wait conservatively, especially for patients who are not highly dependent on their sight. But for instance, teachers, drivers, this kind of patients, even with moderate visual loss, the surgery could be done for them. So the definitive management for cataract is surgery. There are 3 basic techniques: phacoemulsification, intracapsular, and extracapsular techniques. Phacoemulsification is currently the most widely practiced in developed nations. It is the latest surgical technique. So it requires, machines that can break the cataract while they are still in their anatomic position. Then after they break the lens, they will aspirate it with a different device. In Ethiopia, widely practiced is extracapsular cataract surgery with a technique called small incision, manual small incision cataract surgery. So they just open around 5 to 6 millimeter of on the around 1.5 to 2 millimeter from the limbus, and they advance into the anterior chamber and they take out the cataract. Intracapsular currently is obsolete. So if you are asked in your exams which one has the least complication, so phacoemulsification has usually the least complications in the hand of an expert. But the rate of success is almost similar with small incision cataract surgery. Potential complications of cataract surgery include persistent inflammation, change in eye pressure, swelling of the retina, sometimes retinal detachment. So macular edema is possible with CME. Sometimes IOL, once you remove the cataractus lens, you have to insert another factory manufactured lens. So that lens, you try to put it as much as possible into the anatomic position of the original lens, but as a complication, it may be, it may move from the normal anatomic position. So this could be one of the complications of the surgery. So any patient who had cataract surgery needs a strict follow-up at least for 2 months. There is no effective mechanism of prevention, but for instance, metabolic type of or toxic type of cataracts can be prevented. Patients with DM, they can prolong the onset of cataract by tight glycemic control, with exercise and diet control. Okay, otherwise cataract prevention is not even the best strategy for cataract is not prevention. The best strategy is to do as many surgery as possible. All right, so this is all I have for cataract. But if you have any question, you can ask me later regarding cataract. Okay. So let's come to trachoma. Trachoma is the second common cause of visual loss or blindness in our country, in developing, in sub-Saharan countries in general. Trachoma, along with other causes of corneal opacity, other diseases that result in corneal opacity, they are the second causes of blindness. So chlamydia trachomatis serotype A, B, A, and C are the serotypes that result in chlamydia trachomatis, so it's an infectious disease. It is seen in societies usually with lack of water, where there is dust, no habits of face washing, where there is surrounding dirty environment. Trachoma is a disease. So we don't see it normally in the urban area. This is usually patients who come from the rural area and even those who are poor. So this is an indicator for poverty. It's like diagnosing malnutrition in pediatric work. So the presentation, the active type of trachoma, the presentation is redness, discharge, foreign body sensation. So it's like any conjunctivitis. So they may have ocular pain. So this is when the infection is active. When the infection is recurrent and turns into a chronic phase, it results in trichiasis, which means when the eyelash starts to touch the cornea, or entropion, when the eyelid starts to turn inward, Herbert P, conjunctival scar, follicle papillary reaction. I will show you, I think, a picture of this. So generally, what you should know about trachoma is it's a disease of the poor. It is widely, prevalent in Ethiopia and other sub-Saharan countries. This is not a known disease in the developed world. So patients who lack basic water supply are prone for this disease. So generally, two of these four must be there to make a diagnosis of trachoma. So follicle, conjunctival scar, panus, Herbert. I'll show you this. Okay. So this is a picture. There is no active trachoma on this patient. Okay, but by seeing this, this is the sclera, the white part, and this is the darker part is the cornea. The structure that connects the two is called the limbus. So around the limbus, where there is the vascular supply and lymph supply to the cornea, as you can see, there are some dark spots. So this shows previous follicular inflammation. So these are what we call Herbert's pits. They look like holes, so we call them pits. Herbert's. So if we see this, and if we see kind of corneal opacity, we will know that this is a trachomatis corneal opacity. WHO grading, it's important, usually exam type of question. So TF is follicular trachomatis, or this is the inflammatory phase of trachoma. So it has its own criteria to make a diagnosis. At least 5 follicles. I will show you what follicles look like I think I have the pictures on the subsequent slides. So TI is the second stage, so trachomatous inflammation, which means there will be diffuse inflammation on the tarsal conjunctiva. The tarsal conjunctiva is on the interior part of the eyelid. Okay, so the bulbar is the eye globe, the white part of the eye. So at least 50% of the deep phases will be obscured by, if that happens, we make the diagnosis of PI. So trachomatous scarring, or this is trachomatous conjunctival scarring. TT is trachomatous trichiasis, and the last stage is corneal opacity. So treatment, medical treatment can only help you on the first two stages. Otherwise, only surgical treatment can help you. The management, WHO recommends a safe strategy. This is also exam. Since trachoma is common in our country, you'll have one or two questions from this trachoma. So safe strategy, surgery, antibiotics like doxycycline, azithromycin, face washing, so environmental. So safe, the S stands for surgery, the A stands for antibiotics, the F stands for face washing, E for environmental sanitation. So this is, the conjunctiva, the scarred conjunctiva. So secondary to trachoma. So as you can see, there is the eyelash is touching the globe on the cornea. So this is the TT stage. Again, TT stage with corneal opacity. Here, as you can see, there is a clear corneal opacity, central corneal opacity. So the management, the endemicity of trachoma. So if the follicular stage of the trachoma, you do a kind of survey, and if it is less than 5%, you treat them with, just treat the individual trachoma. You don't need to mass intervention. But if it is more than 5%, especially if it is more than 20%, the community in large should be treated. The community, which we mean by school-age children and women. So the WHO recommended the current WHO recommended treatment for trachoma, active phase of trachoma, is azithromycin. Okay, azithromycin for pediatrics 20 milligram per kg single dose, or adult 500 milligram per dose. You can go maximum to 1 gram. So azithromycin, you should know that is a preferred drug, and when it comes to trachoma, medical treatment is only for the first two stages. The rest of the stage, the rest three stages should be treated surgically or by evasion of trichiasis. So if there is trichiasis, that means if the lash is touching the globe, you have to remove the lash. So depending on the number of the lash, you can choose treatment, either whether just to remove the lash touching the globe, or to do surgery and invert the improprium. So usually clinically we use 5 lashes as standard. So if there are more than 5 lashes touching the globe, we go to surgery. If less than 5 lashes, we remove the individual lash. So one mechanical equation is not advised, because once you remove the lash, it will come again in a month or so time. Electrolysis is preferred because it destroys the root of the hair, the lash. So the other option is cryotherapy. You can, freeze the lash so that it will not regrow on that place. The other is WHO recommends bilateral tarsal rotation for improprium. That means if the eyelid is turning inward, you have to, invert it so that the lash will not touch the cornea. By doing so, you can prevent the progression of the disease from being from reaching to the level of corneal opacity. Once it reaches to the level of corneal opacity, it is almost a permanent damage. Okay. Currently, in fact, there are surgical treatments for that with corneal transplant, but it is very complicated because, as we said earlier, it starts from the limbus. So peripheral cornea will also be vascularized. Since it will be vascularized, it will be very the risk of rejection for corneal transplant increases. So that's why trachoma should be treated on the active phase, on the early active phase. If it reaches to the late phases, it is difficult to treat. As a complication, it might result in nasolacrimal duct obstruction, conjunctival scarring. This requires a bit sophisticated surgery with podatosis to rhinostomy kind of surgery. We do that. Even the common cause, one unpublished research shows trachoma to be the commonest cause for acquired nasolacrimal duct obstruction in Ethiopia. So scarring, you don't need to intervene. Just if there is active thing, you can treat it, and you can give some lubrication, topical lubrication. TT stage, psoriasis stage, surgical correction, cornealoplasty, corneal transplant. Okay. So the last disease for today is glaucoma. Okay, so far we have covered cataract, trachoma, and now the last part, glaucoma. I hope you guys are with me. So glaucoma, by definition, the best way to define glaucoma is progressive optic neuropathy involving characteristic structural changes to the optic nerve head with associated visual changes. Okay, there is a misconception of glaucoma that with only increased intraocular pressure. Increased intraocular pressure is not glaucoma. It is the commonest risk for the development of glaucoma, of course. But the true definition of glaucoma is, I think this was one of the questions. I was the first batch to take ARMP, and this was one of the questions which defines glaucoma best. So progressive optic neuropathy involving characteristic structural change to the optic nerve with associated visual field change. So it is an optic neuropathy. It's a multifactorial disease affecting the optic nerve with characteristic visual field defect. And it is commonly associated with high intraocular pressure. But there are glaucoma types that are not associated with high intraocular pressure. We call for instance, normal glaucoma. The glaucoma is within the normal range. So other factors also play in the development of glaucoma. So the normal average intraocular pressure is 16 with plus or minus 2 standard deviations. So the range from 10 to 21. Okay, if you put as a range from 10, or sometimes some textbook put it from 11 to 21. But the average is 16 with plus or minus 2 standard deviations. So higher than that is increased myopia, lower than that is hypotony or low intraocular pressure. And the intraocular pressure is higher in early morning. So this simple schematic diagram shows you how the production of aqueous humor up in the posterior chamber. Okay, this is the cornea. As you can see from my cursor, this is the cornea, this is the lens, and this is the iris. So light comes from here, yeah? But the production of aqueous humor happens in the posterior chamber via the ciliary processes. This A, the designated by A. So it is produced in the posterior chamber, so it has to come to the anterior chamber. And finally, the angle structure here, the trabecular measure. Through the trabecular measure, it goes to the Schlemm's canal, collecting channel, episcleral venous pressure, plexus, then to the conjunctival vessels. Okay. So this is how it is produced and how it is drained. So anything that affects its passage, starting from the iris and lens to this area, the angle structure where the trabecular measure is there, can result in glaucoma. So this is a very important picture. If you want to understand glaucoma, this is a picture that you should always think of. So when we say angle closure glaucoma, and when we say open angle glaucoma, the difference is from the angle around here. Okay, this is the angle between the iris and the cornea. Iris cornea angle is the most important angle. So in angle closure glaucoma, what happens? Usually the mechanism is pupillary block type. So there will the contact between the iris and the lens will be strong. So fluid aqueous humor cannot pass to the anterior chamber. So what's going to happen is it will start to push the iris anteriorly towards here. So the angle will be closed. So when you see it from the anterior aspect through a slit lamp, you see the angle being closed. So we make a diagnosis of angle closure glaucoma. The management is different from open angle glaucoma. But in open angle glaucoma, the anterior chamber is deep, the angle is open. So when I say the angle is open, so here you can see through your microscope, you can see that the angle, you can see the angle. But in angle closure, since the iris comes in contact with, depending on the degree, in contact with the cornea, the angle will be closed. So open angle, closed angle, this picture should be, you know, you should remember this picture. So pressure is usually more than 21 to be associated with glaucoma. The normal cap to disc ratio of the optic disc is less than 0.4, but this is not, you know, in a real practical scenario, this is not, you know, that much important. What is really important is if the discrepancy between the two eyes is more than 0.2 when it comes to the optic optic disc neuropathy. The most important is the discrepancy between the two eyes. This number by itself doesn't mean anything, because there are patients with 0.7, 0.8 cap to disc ratio, but still no glaucoma. We see some other parameters, you know, the so-called physiologic capping is also there. Okay, so capping, one of the signs of glaucoma anyways is capping. So normal is less than 0.4, abnormal is more than 0.6, but the most important is discrepancy between the two eyes more than 0.2. So the other important thing, vision loss in glaucoma starts with peripheral vision, not central vision, okay? So that's why patients present very late, because their central vision is not affected, they tend to come very late. So, and most of the time it is asymptomatic. So screening is very important when it comes to glaucoma, especially patients who have some medical and family history, visual acuity testing, for screening, slit lamp examination, ophthalmoscopic examination, direct, indirect, or through VOC lens, through direct fundus examination. The other important is tonometry. Tonometry means measurement of the intraocular pressure. So it could be by applanation or by indentation to measure the intraocular pressure. So the other criteria is visual field. So visual field test. Currently, there are a lot of mechanisms to do the visual field test, but the simple one, by simply confrontation in your office, you can sit 1 meter away from your patient, and you know, by looking straight by sitting at the same level with your patient, you can make him hold one eye, and you can show him, you know, some red tipped small structure, so from periphery to the center, or from the center to the periphery, until the patient starts to see your this object. So this is simple confrontation, but there are tangent screening mechanism, FDT, Humphrey visual field analysis. Humphrey is currently almost a gold standard, but there are also other machines currently. You know, the science of glaucoma is increasing currently. So even in our country, up to fellowship program, there is fellowship in black line. So glaucoma is an interesting field to study. But generally, when we summarize it, so optic disc assessment is one criteria for the diagnosis of glaucoma. Increased intraocular pressure is the second important parameter. The third is visual field test. So out of the three, if you have two, you can make a diagnosis of glaucoma. This is a WHO recommendation. Classification, primary open angle glaucoma. Open, so when I say open, you have seen the picture, the previous picture I showed you, so the angle is open. So what happens is there is a resistance to the flow of the fluid in the trabecular measure. We don't know exactly what caused that resistance, but there is a resistance in that trabecular measure in the angle that I showed you. The angle is open, but the fluid cannot pass through it adequately for a reason we don't know. That's why it is primary. Primary, we don't know the cause. and it is open angle, and that is the commonest. Usually it is an exam kind of question. So which one is the commonest cause of type of glaucoma? So there are risk factors for the development of primary open angle glaucoma. So the first one is increased intraocular pressure. So when you measure intraocular pressure, if it is more than 21, the chance of developing glaucoma is higher. Some studies show that it is more common in blacks, in myopic patients, myops, short-sighted patients, in patients with central corneal thickness less than 520 micrometers. So the normal central corneal thickness is around 540 micrometers. If it's less than 520, the risk of developing. So the other is always the familial thing, and the inheritance the type is polygenic, and it is more than 10 times from the general population. If you have a family history, you have 10-fold increased risk of developing glaucoma. So if someone have a family, parents, or siblings who lost their eye to glaucoma, it's better to screen him at least when he reaches the age of 35 to 40. So chronic topical steroid use, previous ocular trauma, and hemodynamic crisis, hypertension, these actually are not confirmed. Okay, chronic steroid use, it results in open angle glaucoma, but it is not primary open angle glaucoma. I think we can remove the statement from this. So don't be confused, okay? Chronic topical steroid use, if a patient uses steroid, so we know the cause of the glaucoma. So that's secondary type. So the symptoms and signs, the problem with glaucoma, especially primary open angle glaucoma, is that there is no symptom. It is insidious, less gradual rise in IOP, in which the patient is not aware of. Usually it is bilateral around 60-70% of the time, but asymmetric. Visual field loss, it is all again slowly progresses slowly, but the visual loss is irreversible. So they will have capping. So unless they come for, we usually make the diagnosis of primary open angle glaucoma when they come for other complaints, like they may have patients with foreign body sensation, tearing, redness, for conjunctivitis. They come that, and a good physician would look also the disc and would measure the intraocular pressure. By doing so, you will pick primary open angle glaucoma. For me, it is one of the most frustrating diseases because I usually get my patients once they become blind, and telling your patients that there is no management that can be done it's a bit frustrating, but it is what it is. I have really a lot of patients, even in this small town. We have a lot of patients who come with terminal glaucoma, a very easily treatable disease, progressing into a permanent blindness. Hey, your patients, when you tell them that it's not going to be, they want you, they tell you to refer them. Some of them have even financial capacity, but once it is, because glaucoma is reversible disease, the damage to the optic nerve is irreversible, so it's not possible to give their vision back. So how do we manage primary open angle glaucoma? So the main treatment options, surgical, medical management. Medical management, we start with beta blockers. Everybody knows timolol, so you can start with beta blockers. They have their own side effects, especially patients with cardiac and asthmatic patients. You should be very cautious. It's better to start other categories of drugs like prostaglandin analogs. Prostaglandin analogs currently they are becoming first-line medications. So for primary open angle glaucoma, for secondary glaucomas like pseudoexfoliative glaucomas, these prostaglandin analogs are becoming first line. They decrease the intraocular pressure by around 33%. Beta blockers, they decrease by around 25%. So for instance, if you have a patient with intraocular pressure of 30, you have to plan by how much you have to reduce the intraocular pressure. So that's the main management plan you should put forward. So miotics like pilocarpine, alpha-2 agonists, brimonidine, aqueous anhydrase inhibitors like dorzolamide. These are common drugs, and these I selected these drugs because they are also available in Ethiopia. So the other important drugs are combination drugs. So timolol, dorzolamide, these are commonly available drugs. So if the intraocular pressure is high or the stage of the glaucoma is late, you can start your medical management with a combination of drugs. Okay, so when you combine two drugs, they will have a synergistic effect. The surgical management could be laser or surgery. So the laser could be SLT or ALT. So these are a kind of specialty treatments. Especially the laser treatment, they can be given as primary treatment, or they can be given in collaboration with medical management. Okay, so you can give both medical and laser treatment, or you can start your first treatment with laser treatment. Currently at Minilik Hospital, both SLT and ALT are available. So especially young patients with glaucoma, they can start with rather than making them. Since this medical management is a lifelong treatment, you can give laser treatment initially. If it succeeds, the success rate and the recurrence is high. Anyways, you can start with laser treatment. So you can start with laser or medical management. If you fail, you go for surgical management. So incisional surgeries, diversional surgeries, drainage surgeries, these are the possible types of surgeries that can be done. So the whole idea is to stop the progression. Okay, the second type of glaucoma. The other important thing for you guys to know is the glaucoma around the world, the prevalence varies. Okay, primary angle closure glaucoma, around 12% of all glaucoma cases. So as I showed you on the picture, the peripheral iris bows forward in an already susceptible eye with a shallow anterior chamber. So usually they bring this angle closure glaucoma in they describe a patient for you. I will show you how they describe it. So the risk factors: hyperopia. So hyperopia for angle closure, myopia for open angle. So usually females above the age of 70, patients with big lens, family history always is there. Mature cataract, as I showed you. So if there is the contact, iris lens contact is strong, the angle will be closed. Shallow anterior chamber, pupillary dilation. That's why sometimes when you give medication like topical anticholinergics, they might induce angle closure glaucoma. Okay, so symptom usually it is unilateral, but around 50% of the time the other eye is also involved. It's a matter of way. So prophylactic treatment is sometimes even is recommended. If one eye is affected, the other eye should be treated prophylactically. So what happens is your patient comes with red, painful eye. They may have vomiting due to the pain. They will have decreased visual acuity. They will have blurring from the corneal edema. And they will tell you that they have halo around lights. They see halos around lights. So nausea, vomiting, abdominal pain. And when you palpate the eye, it is firm, which shows you that the intraocular pressure is high. So if they describe a patient with these symptoms, go for angle closure, primary angle closure glaucoma. Okay. And on examination, they will have mid-dilated fixed pupil. They will have corneal edema, conjunctival injection, that means red eye, and the anterior chamber is shallow, and there are cells in the anterior chamber. It is very, these patients will come acutely, but the management is very difficult, and they may have irreversible loss of vision. But still, if they come on time, you can break the angle closure by different mechanisms. So the management immediately try to preserve vision, try to prevent adhesion. Since angle is closed, it might be permanently together. So you need to plan for that so that it will not adhere together. So the previous picture should come to your mind when I talk about this. Otherwise, you may not understand it. So medical treatment, myotics, because the peripheral iris is touching the angle. So myotics, they are pupillary constrictors. So to bring back, the both iris anterior towards the center. So myotics are drugs of choice, but mydriatics are contraindicated. So usually on the exam, which one of the following is not a management option for angle closure glaucoma? So they put mydriatics on the options. Mydriatics are contraindications. The other is topical beta blockers. So topical beta blockers you can give for any kind of glaucoma. Systemic carbonic anhydrase inhibitors, so Diamox or acetazolamide PO can be given, should be given actually. Systemic hyperosmotic agents like oral glycerin, IV hypertonic monitor. So it's like managing increased intracranial pressure. It's like managing ICP, okay? More or less, it is managing ICP. So if it does not respond to your topical and PO medications, you have to go for monitor. Topical steroids, because we have said there are cells inflammations, so to decrease that. Surgical treatment for an acute angle closure glaucoma is laser iridotomy. So let me show you laser iridotomy on that picture. So we will open. So since the angle closure is happening around here, you will just open the iris, a hole on the iris, so that it will not go anteriorly, rather the aqueous humor flows through the opening, okay? So this is what we call peripheral iridotomy. It could be done surgically or through laser. So this is pretty much how you manage angle closure glaucoma. Secondly, glaucomas, they are very detailed, but the commonest in Ethiopia secondary glaucoma is pseudoexfoliation. Actually, globally as well, pseudoexfoliation glaucoma is common. In Ethiopia, a study done in Jimma, in Minilik Hospital, they indicated that pseudoexfoliation glaucoma is the second commonest type, next to primary open angle glaucoma. The Jimma study even showed that exfoliation glaucoma has higher rate of prevalence than even primary open angle glaucoma. So, but generally, primary open angle glaucoma is the commonest for your exam. The second commonest is primary angle closure glaucoma. Then the secondary glaucomas comes. Thank you very much, everybody. This is the end of my presentation. If you have questions regarding my presentation or the topic that I raised, you are welcome to ask. Thank you.
All right, thank you so much, Doctor, for the amazing presentation. So I think there are 5 questions in the Q&A section.
Okay, so I thought the most common cause of blindness is DM. So the answer is no. DM is an important cause of blindness in young adults in the West, but still, even in the West, cataract is a common cause of blindness. What is diopter? It is a measure of the power of the lens. It's like meter for distance. Diopteric power is the power of the lens. So what it means is the reverse of a meter, 1/meter and the ማለት for diopter. So your second question is that. The third, how do you see wearing sunglasses without sight problem? The question here lies on the type of the sunglasses we use. Normally, UV radiation is one of the most damaging things currently. In my clinical practice, currently young patients, especially workers, bank workers, teachers, the most common complaint is photophobia and dry eye with the usage of phone, computers, and also direct sunlight exposure. So wearing sunglasses in during sunny time, it's advisable. But where do you get these sunglasses? You should get it from, legally በህግ ከተፈቀደላቸው የመነጽር መደብሮች መግዛት ነው እንጂ because sometimes these sunglasses they may be highly reflective and they will do more damage than benefit. But standard sunglasses, they are good. I recommend for everybody during this some winter time. It's a good question. How is the prevalence of trachoma in Ethiopia by region? You know, I cannot give you a specific numbers here because there are no published standardized data regarding the prevalence by each region. But what can I tell you? What I can tell you is it is highly prevalent in the northern part of Ethiopia and in the most rural aspects of Ethiopia. It is generally a disease of the poor and a disease of the rural areas. But the prevalence by a specific region, I don't have the data for that. Okay, Dr. Haba, the other question she asked by Dr. Haba is, what is peripheral vision? So what we mean by peripheral vision is, for instance, there is someone just sitting right in front of you. So with moving your eye, you are aware of, some of what's happening around that individual. You are focusing on the center. So you are looking at your primary gaze, but on the periphery, you know what's happening, right? So that is a peripheral vision. So peripheral vision is a vision that tells you so the extra fixation area. So you fixate on one particular point, and the point surrounding that particular point is peripheral to you. So simply that is what peripheral vision. In glaucoma, the problem is it affects peripheral vision primarily. The central vision, even with the most advanced type of glaucoma, they can sometimes they will have visual acuity of 6.6 because it's their central vision. We sometimes call it tunnel vision. Okay, so since it is not affected, since the central part of your vision is not affected, they tend to come very late. So peripheral vision is extra fixation vision. You fixated on one point, but your awareness around about your surrounding is through your peripheral vision. So that's what we mean by peripheral vision. So this is, I think these are the questions that I see. Okay, there are other questions. Prahanu Bellata, how thin is CCT cause POAG? So as I told you on my presentation, the normal corneal thickness is around 540 micrometer. So 540. So the risk is when it is less than 520. Okay, so the standard is 540. If it is less than that, if it is less than 520 especially, it is a risk for primary open angle glaucoma. Okay, what is the effect of long-standing reading on computer screen and vision? So I can tell you two possible outcomes. One doesn't journey. So, when you read, the first problem arises from the rays that emanates from the computer or from your phone for that matter. So especially, the UV radiation, the visual spectrum, the wavelengths of light varies, even the visual light is from around 420 to 700 wavelengths, okay? So these are the wavelengths of light that we are able to see. So when you are exposed for a prolonged time from your PC, there are short wavelength lights that comes that are less than 420 nanometer. Less than this can be damaging to your eye. Normally, nature has provided us with defense mechanisms, okay? So your corneal epithelium filters most of the lights, the unnecessary lights, but the UVA light, that means the short wavelength light, the blue light, we call it, when you are exposed to PC for a prolonged time, normally it should be filtered by your lens, but some of the rays could reach to the retina. So when you are exposed for a longer time, you may complain of visual reduction because of temporary toxicity to the retina. And if that continues, it might result in permanent damage. It's rare because the human lens can filter UVA, but especially patients who had cataract surgery, they are not advised to see computers for a long time because unless it is painted lens, the artificial lens cannot do this job as the normal human lens. So one aspect is when you are exposed for light for prolonged time, you may have retinal toxicity. So this is one. The other is there is what we call a myopic shift. Okay, you understand? So at near vision, normally your eye is in an accommodated state. That means your dioptric power, the lens dioptric power increases and the lens thickness increases. As a result, when you do near activity for a long time, the chance of your lens remaining in an accommodated state increases. So myopia happens. So when you try to see distant objects, you'll have some kind of blurring because your lens is not adjusting itself back to the normal position. So myopia could come and retinal toxicity could be there. So maybe if we observe, since when you are using your computer for a prolonged time, your blink rate decreases. So normally we don't notice that, but we blink 20 to 30 times per minute, okay? But when you read from computer, the blink rate significantly decreases and that results in dryness of the eye. So this is directly associated with sometimes heaviness in the eye, foreign body sensation, even sometimes corneal irritation, and they may come with acute pain. So prolonged usage of computer screen is not advisable, okay? And for your surprise, majority of my patients come because of this. Okay, can you please repeat the dioptric measurement? It is 43 diopter. So the highest dioptric power of the eye is cornea. It is 43 diopter. The lens is 20 diopter. The cornea is 43 diopter. Okay. So computer vision syndrome, I have already explained it with Wanda Sanchani's question. I don't advise. Galaxy asked about empirical and over-the-counter use of dexamethasone. I don't advise. Even patients with allergy, it's better to be seen, okay? Because sometimes, for instance, herpetic eye disease, they mimic allergic conjunctivitis, and you may melt your cornea. The other thing, dexamethasone, as I already explained, is a risk for glaucoma. So unless it is absolutely necessary, it is not OTC drug, not at all. safe strategy, okay? WHO safe strategy. So I think we better conclude, right?
Yeah, we should conclude. Thank you so much, Doctor, for taking such a long time for the presentation and also for the question and answer. It was a really honor to have you here. So if you have any last remarks regarding the topic or regarding anything, I'll give you the stage one last time and we'll conclude.
No, I think I have said enough today for today.
All right. Thank you so much, Doctor. Have a good night.
Okay, thank you very much.